alongside everything else that's going on nationally, is a real opportunity for us to shift into a different way of designing and delivering counter-terrorism media long term. Video, are we ready?
Are we good to go?
Yeah, so this just gives a bit of a flavour of why and what we've done so far, and then we'll go.
Should we do the video again and give you a bit more time?
Yeah.
Sort the sound. So Gemma, you want to go through?
I was going to hope some slides, so I think that would be helpful. Or just restart. You have got.
There we are, slides.
Great, thank you. I'll leave next slide to you. So, as I've already said, that intro is what we're here to do. So you may have seen these. We've come to you, I think, twice now. So these are just some of the objectives of what we were trying to achieve through Hampton Citadel in 2014. It started before 10-year plan, before ICB, structural changes, but interestingly has kind of started adopting quite nicely those objectives. We wanted to look towards a medium long-term sustainability strategic approach. And so this was always a test and learn experiment, a way of working, and to shift towards population cohorts, a prevention-based approach, and working with people, but also in the recognition of where we were 18 months ago. We wanted to instill hope, alignment, a clear shared vision across our systems. So that's what was the rationale behind all this, with underpinning needs to improve healthy life expectancy. A lot of the national evidence is pushing us in that direction. So next slide, please. And we came to you, I think it was last September or October, next slide, to make a recommendation to first work on the working age population. So we identified the third highest use of emergency care system are people who are in their 40s, 50s, 60s, living in poor health now, expected to live for the next 15 years in poor health and will be the future frail population. And so a real opportunity to redesign community-based care, embed more prevention, and start to integrate around the needs of this population. So that's what we've spent the last year or so doing. Next slide, please. And what's been our approach? So we have gone through, we started with an evidence review, an underlying assessment of what the data is and what the need is, which led us to some design principles that said these are 10 things we have to address if we want to address them. We did that in January of this year, which then took us into a design and test phase. So we ran 3 design events with about 80 professionals across the multiple departments of the system, 10 focus groups with 60 members involved, as well as surveys with staff, with public, 350 ideas generated, 15 concepts created, and then we examined, we'll go into more detail, of 5 system conditions. And we really trialled the use of different tools, which some of which you're aware of, so Green Horizons as a futures tool, user design, and something called system craft, which is really understanding how our system needs to be structured to get to this new way of working. So all of it is really data-led, evidence-led, insights-led, working with people and us playing a role of bringing together experts across the system to come up to, as generate a set of solutions aligned to these design principles with the evidence that we generated. So what I'm going to talk through now is what's going on at the strategic intentions that have come out. So next slide. And the first strategic intention is around model of care, which just kind of put healthy neighbourhoods, because this might inform how we our neighbourhood model of the future. So next clip, please. When we went to the focus group, we developed up 5 concepts, as I said, component parts. And I was in one focus group where one gentleman, based in been out of work for about a year, based on a few different health conditions, said, well, that's nice, but I need all of them, really, to be happy. You want me to be healthy, but I need all of them. Which led us to take that further into our final design event, and we started to build the idea of what if we have these connecting components. And really, it started to be the answer. We can't just look at one part of this. We need to look at holistic needs of this population. So there's a lot more detail in the papers, but just to put out a few. The idea is that people starting with this target cohort move to having a health and wellbeing plan, worked out with them, that then plugs them into an integrated team. There are people who coordinate their care, as well as work with what helps you be healthy, what are your challenges, what are your barriers to being healthy. Some people told us this was their children weren't going to school, they were caring for elderly relatives, they were in so much pain they couldn't leave their house. They were struggling to navigate a very complex health and care system that fired them lots of different directions with lots of letters, with lots of test results that they had to navigate that admin themselves. So the idea of an integrated team based at a neighbourhood that works with people to prioritise their well-being plans. And then there's a rising risk cohort who identified about 38,000 people who are going to be in this same situation in the very near future, unless we do something different. And what people told us was that having somewhere to go where they could get questions answered, basically that health, be that wider social need, and some of the emerging models around neighbourhood hubs for children's and family hubs was a kind of model that was being looked upon, and so having increased access to rising risk cohorts with digital support. And a lot of this, just so where this has come from, we had GPs in the room who were saying, I don't need to have 10-minute appointments for everyone. Some people I need to have 25-minute appointments with, some people I don't need to see. So that's what's behind this model. There are hospital-based consultant specialists in the room saying, I think I could be a lot more impactful if I were out there in general practice helping support a wider network of people rather than wait for everyone to come to me. So that's what's behind all this. So we put in the strategic intentions the idea of changing appointment lengths of time, the idea that we will phase out outpatients for people in this community, and that outpatient appointments, people who live with these kind of health conditions, will be delivered in their neighbourhoods in a partnership-based approach. And that mental health and physical health is starting to treat as completely interlocking. You can't manage someone's physical health, we can't manage the diabetes pathway separate from someone's mental health and pain. So starting to see that as all connected. So that's the model that has been developed. To finalise on that, the intention here is it's a shared vision. We can all work together, start to design the intricacy behind it. There is so much detail, planning and modelling that would need to be behind this, but this is the vision, the direction of travel. Next slide, please. And then we've identified 7 other supporting conditions that we need to work on. Run through quickly to more detail in the document, but we need to align our incentives and pay so that this model is the easy thing to do, rather than pay component parts, which is what we've been doing for at least the last 15 years. That data and community insights are at the forefront of how decisions are made, how services are continually evolving and shaping. That we actually pay the outcomes that matter. Developed to outline outcomes framework that again is in the document that came from all those workshops and with people and with a review of the benchmarked national and international outcomes. The digital tools are embedded as part of models of care rather than having something separate. And there are lots of people, we don't have an app for every single disease, we have apps to help people be healthy as well. A strong thing for this is more shifting towards a relational culture, a relational way of working. That someone in your neighbourhood knows you and says, hi Brenda, has your son gone to school this week? So I know that's a barrier for you. And that we start to develop a model that means that people who are care coordinators have caseloads of families, who know those families, and who are working with them to help them be healthy as well. That's a big cultural shift, but that feeling is fundamental on which we're talking about. Healthy workplaces, many of these people are either in work and struggling to stay in work or long-term sick, or have left or retired early. Workplaces is a massive opportunity, and starting with us and set workplaces, that's one of the intentions we put forward, that we start to build a network around health at work. finally, a learning curve system. This model will, as we've learned, as we've gone through the last 6 months of work, things are rapidly changing around us. We need to hold that vision but continually adapt as we build in all the data and learning and insights from the public. And some of the things we've recommended is a trusted listener role at a neighbourhood level through a big city alliance. We can actually hear and have that dynamic with the public as we start to establish with these focus groups. And whilst also using our population data, we currently hold it at ICB level, having that available at a neighbourhood level so people can see how the population is. So, like I said, there's a lot more in there. Yes, there is a lot more to do, but it provides that direction of travel for a shared vision. Can I have the next slide, please? What have we learned? Focusing on people and need brings people together. The doors have magically opened on many conversations I've had. We haven't talked about organisational boundaries or which organisation is aiming towards. When you start to talk about people and shared needs, it brings people together. Data-led, insight delivery, valuing experts from all angles has been the core principles, and that's helped us navigate through some tricky times. Again, as you start thinking to an organisational lens, it gets tricky. You start looking at the real data and people, what they tell us, and the answers that we want to do. Like I said, we developed this locally, and then nationally, we've seen this docking into a national vision, so we're continually reinforced that what we're doing is along the right track, but this has come from people in the conversation we've had with people and people who work with the organisation. So a wider agreement everywhere we've gone really has just been saying, yeah, we want to move away from I've got a specialist nurse in diabetes, I want to have a team who's able to look at people who have specialisms they can tap into behind the scenes. I don't want to fragment the services anymore, for example. We've used many tools that have had really positive feedback, that bring people together around a shared agenda, vision for the future that have given people that sense of help, that hope, alignment, and appreciation that there is going to be a better future, but it's not going to be as disconnected as we have been, particularly kind of post-COVID in the last few years. A lack of hope, a feeling that it can't address kind of the concerns and needs of the situation. So I'll just wrap up on the last slide. As I've kind of touched through, we've still got some big questions to answer. So as we move into the next phases towards implementation, scale, do we keep it at this scale? Do we think about different scales? What's the scope? Start with Gloucestershire, but there's a real data and insights-led piece of work. We want to go back and make sure that their population have the same needs before we decide if there's any applications that would be for the Gloucestershire population. Governance, pace, some of them set nationally. So we are already, and after today, like I said, the key milestone for us, we've already set some things in motion, which again are a document about how we move those what we call first next steps. So I know GPs at GPEN came to you last session before. Those 17 or so practices, obviously someone was going first, working out trialing how this would work. They've got some care coordinators they think that they can make progress next, as well as some in North Somerset and Gloucestershire as well. So there's a real willingness to kind of take this forward and trial as well. We think there's an ICB and moving into a period of time where we have to deliver on strategic commissioning whilst also balance organisational change. The areas that we really need to focus on are that the outcomes development, the outcomes we've set out, is that really pivotal to maintaining the shared agenda and measuring change. Year of care, tracking arrangements, so paying things differently, less individual pathway payments, bringing it all together, paying for people to be healthy and well for a period of time. Developing target operating model for this population and for neighbourhoods, informing neighbourhoods in general, and then defining with Gloucestershire how we work this forward. So, and we're also embedding in planning and then procurement of a target operating model with a lead in that this is a kind of 1 or 2 years development, and that's years 3, 4, 5. So, final slide is really this has been, we've been very clear that we're kind of architects of the process, but we have not been defining the detail that has genuinely from many people in the room, experts by experience in all different ways. We've pulled this together, we've kept momentum and we've built some of the tools. There's been a load of learning, but really there's of those people who have been involved. So I don't know if the video will work now.
Give it another go.
We could have a try, but
Unlucky maybe?
Right, the sound will be a bit quiet. It won't connect to the room speakers, so we're going to have to go through the projector sound. So you'll be able to hear it, but it will be a bit quieter than we hoped.
Imagine a future where everyone in Bristol, North Somerset and South Gloucestershire can live healthier, happier lives. Healthier Together 2040 is our plan to make this vision a reality. Thousands of working age adults in our area are currently living with multiple long-term health conditions, and this number is expected to grow by 50% in the next 15 years. We're beginning our work by focusing on people in their 40s and 50s who often face the greatest challenges. Through 3 design events and a series of public focus groups, we've been working with health and care professionals, voluntary and community sector partners, and people directly experiencing these challenges. Together, we're building a clear picture of who may be missing out on the care and support they need. We know health isn't just about doctors and hospitals, it's also about jobs, housing, income and stress. For people already managing several health problems, these everyday pressures make life even harder. Mental health is just as important as physical health. When people feel supported emotionally, they're better able to take care of themselves and those around them. With the right support, we can make a real difference earlier on. But right now, too many people feel passed from service to service without anyone seeing the full picture. Juggling multiple health conditions can be overwhelming, making it harder to balance work, home and health. Living with chronic pain, anxiety or depression adds to the challenge, yet the health system still treats these as separate issues. That's why we're working on solutions that focus on relationships, community and connection. This builds directly on the priorities of the NHS 10-year health plan and designing care around what really matters to people by listening and learning from their experiences. Our aim is simple: care that works for the whole person. That means joining up support from healthcare, communities, workplaces and everyday life, so people feel seen, heard and helped. Healthier Together 2040 is already taking shape. Together, we're not just imagining a healthier future, we're building it.
Okay, thanks Gemma. As always, very comprehensive. Big thank you, because I suspect lots of people around the table have seen you and the team in so many different places, having the conversations around this. So the stuff you talked about isn't rhetoric. You have been doing it, and it's formed what was a really comprehensive presentation for us, so big thank you. I suspect we've got some questions. I'd be really keen to make sure you get what you want from coming to the board today. But let me open up for questions. So Steve, first of all.
Thank you for that. Thank you for the work you've done so far. Just a couple of quick observations. One is how we join this up to reach the really hard to reach communities. Just to make sure that we're in our groups, we've got the right folk giving us feedback. The second bit is what we learned from COVID was digital poverty is a major barrier to many communities. So if we're looking at digital tools, we need to try and find a way of addressing the digital poverty that sits there, especially in that target age group, interestingly, as well as in the younger age groups. The third bit is whether we could work with the combined authority and education to create some opportunities whereby we are delivering education and skills for people to be able to manage their own health care needs. There may be some funding that sits outside the NHS systems or the social care systems that allows us to begin to equip populations with information so that they can manage better their health needs. And that would be involving schools, communities, colleges, universities, that whole agenda, which suddenly brings a bigger workforce into that play.
Is that one for Gemma or is that one for you, Shane?
No, I think more than happy,
Okay.
Gemma.
Yeah.
Go ahead, Gemma.
So in terms of the process so far with the hard to reach communities, we worked with the BCC sector through the BCC Alliance. There were focus groups held with taxi drivers in Boston, with health and happiness hubs in South Gloucestershire, through some of the central Bristol community groups. So we very much work with partners rather than assuming the ICB can do that. I kind of see this as a spiral. We've done the top loop, the spiral. The next spiral down, so we've done this within openness, we expect that to happen again at water. So we keep spiraling down. And the whole idea is that this is a kind of a universal offer with tailored approach. And the tailored will be, as we move into a strategic commissioning perspective, an expectation as a commissioner for collection of providers to be responding to a local need. And I can see that in the data over time. Digital policy, yes, and the action we put in the next step with the digital task force, with a combination of clinical professional leaders and members of the public to come up with recommendations on what's the best digital solutions. We're going to need to spend like that, bearing in mind not everyone how flexible. We have had weather involved. We are involved with the health and work plan and the regional planning. Regional planning program, and kind of trying to find that as a neutral connection point. But yeah, again, there's lots of opportunities. There's got a lot of work in health agenda, but also lots of funding from the UWP, so we've been very much credit to that.
Thanks, Gemma. Alison?
I think this is really good, and in my heart I'm really excited because this is exactly where we need to go. Personalised care which is joined up and letting people be in control of things. So the what speaks to me. I think that's really good. I think my main focus is on the how, really, and not to go into too much detail, but I guess just picking up from Steve's point, we have so much data about our patch that it's almost not the data about what it's telling us or where we have reached, it's what the data isn't telling us and what the gaps are, because I think we could probably say quite clearly lots of examples of where we've reached, and I don't know if hard to reach is the right phrase, but those cohorts probably. I think what's the data not telling us and where are we not getting? I think that's quite important. But the big thing for me about the how, which will make this work or not work, and clearly I support outcomes, clearly I'm supporting neighbourhood, but the alignment of incentives is not a 5-minute job. You know, this is big stuff. So just in terms of what we think we can expect, and obviously I've read there's not much on it, there's a paragraph, and it's a biggish paragraph, but it's a paragraph. But below that, there's just such a world that we're not in at the moment. So how do we get, because that's one of the big mitigations you've put in the risks section, the mitigation around alignments of incentives. So is there anything more you can tell us about your thoughts, what you're worried about, what you're excited about? What can we do as a board to help this bit work?
Help as well, but
Yeah.
So I think that I'm involved in a national working group on this. Interestingly, through the national, and it's been some of our previous experience, but previous because we haven't really focused on changing incentives for the last 8 years or so. Nationally, they recognise that there hasn't been any major shift in financial flows for the last 10, 15 years. The skill set around this is weak. There's not a lot, even nationally in England, there's a lot of lack of knowledge about how we can do this. There's a push through that group for us to make progress by April. And if we can make some progress by even just being aware of what we're spending, how it aligns to the nation need, I think that's going to be our next step. I think as we move towards the strategic commissioning based organisation, it will be something that has to work out how our organisation focuses on that.
I mean, certainly, Alison, there are 6 pieces of work being done nationally to try to enable the 10-year plan. And in one of those 6 pieces is talking about finance, the movement of money, incentives, etc. There is an intention to have a first understanding of that piece of work on the 16th of September, I think the meeting is in London. Now, what I would say is that I'm involved in one of those strands. It's just so complex, and I'm not involved in the finance one. I'm involved in the IHO one. Okay. It's just so complex, and it's sort of fizzing about a bit. So I do think what we might have to do is do our own sort of test of change stuff, try some stuff, play some stuff, rather than waiting for the national agenda, if I'm being honest, because I just fear that there's just so much going on in that place, and I would be really keen to support us trying some stuff next year, as opposed to naturally expecting the national NHS to give us the answer.
Okay. Thanks, Shane. I've got John, Jaya, Joe, and then Fiona.
Joe.
Right. Thank you, Joe. Thank you very much. It's great to see this coming to life. It's really good to see. I was interested in the healthy workplace, healthy communities strand, and you touched on it briefly. It would just be helpful to hear a little more about what you're thinking around how employers will be engaged with, well identified and engaged with, and how this will align with arrangements that might already be in place. I'm thinking about some that might say have occupational health arrangements versus others. And it'd just be helpful if you could kind of bring that to life a little bit. Thank you.
Okay, so, well, I suppose it's worth saying that we've been working with Worker, they were on the steering group from the beginning with the view that that's our link in as employers. It's been a hard one, really, as kind of led to, we tried interviewing them and surveys, but I think employers and like the employer sector of the region found the struggle to engage with us. So I think it would be something we'd need to continue to work on. So that's where we thought we'd start with us as a partnership of employers and organisations. Let's start with ourselves. And one of the intentions we put in that came through strongly, so many of the population of carers and that many people are employed by caring-based organisations. So we start with our immediate workforce and trialling whether, as large organisations, we can provide more occupational health support to smaller organisations, the BCSE sector, caring-based organisations, so that we can help people have access to occupational health earlier, and see if that is a model that is economically viable, something that we could access, that would be a starting point. We have had some links with some of the bigger employers as well, so non-public sector, but I think it felt like very different languages at this point, so let's start with something that maybe we can do within ourselves as employers. That's in there as strategic intention. Again, lots to do, and the final thing to say is, working really closely with Worker so that these two strategic approaches are aligned, and that we've certainly given them things they haven't thought of, through this work and vice versa. So just kind of still at that strategic level in terms of the wider sector.
Thanks, Janet. Jaya, Joe, and then Fiona.
Thank you. Just to say as well, loving this work. It does fill my heart with joy that we're still carrying on with this and finding ways to make sure that when we transform, that we're going to keep going. Love the approach with it takes a village approach, but I've also heard this in schools in terms of reaching out to every single child as as an individual rather than as a collective. And joining things up at schools would be really key. We've talked about how we join up with the employers. Certainly the West of England initiative is like the bigger employers that also get it, so I don't know if you've already been working with them, but I can certainly introduce you if that's helpful in finding a way to speak to employers who get it, who understand what you're trying to do. And also how we join up with neighbourhood watches, generally positive activism. I know we have a gentleman here who's very hot on the environment, what we need to be doing, and could be joining our efforts up with what's happening out there in nature, because we need purpose for one of the key things of happiness. Love this work. If I could go on forever, I'll stop now.
Okay. Thanks, Jay. Joe?
Yeah, speaking from Alison's point about what is the data not telling us, I was having a little bit of a reaction to that, Alison, because one of the things, we have got lots of data, and apart from a few exceptions, like I see over there, so women who have given up smoking at a time of Jubilee, we've had a real relentless focus on it, and we've had impact. And the problem we've got, I think, is often we're spread so thin, so we're not consistent, and we don't do it for a long period of time, that if you look at the health and equality data, which I'll appreciate you at the next board, they haven't really shifted much at all. And so we need to be careful we don't keep over-analysing and over-diagnosing. The trick here, and this is why I really support this, is to move into positive action, to do something about at least some of it, start to move the curve. But the safety netting of that, I think, is the quality control mechanism which strategic commissioning is about. Because you will watch your data, because data is not just about diagnosis, data is a way of keeping us in the guardrails that we all agree. And if we're going into that, then you go to it, then you go and see what the data is not telling you. We just need to be really mindful that we've got to shift ourselves from interest and curiosity and data analysis into actual action, which is what this is telling us to do. So I suppose it's hold that thought, keep it in mind, but don't make it another stream of activity, because we'll miss the point, miss the target. Hit the point, miss the target.
Thanks, Jill. Fiona?
Thanks, Gemma. Absolutely fantastic piece of work. As VCSE Alliance, we've been involved from the get-go, and we really welcome this. This is a paradigm shift. My concern is that we've got a lot of ambition here, but it's the how. How do we shift the system so that we move away from it being a very medical system to a human system, and how we put the human at the centre? So we talk about hard to reach. Well, I talk to my colleagues and they say, we're not hard to reach, we know where we are, it's the system that doesn't reach us. So if we move to that focus that actually as an individual the system works around us, we're not having to engage it. Outcomes and I agree with Joe, outcomes is a really important issue. And we've already heard about the Intelligence Centre this morning and the work that's going on there. I think that's a key point. But it's also, how do we harness the data and the insights and the impact of the VCSE. VCSE and community is integral to the success of this. We're very much part of this, but it's how we all step up to the plate and how we deliver. But in relation to those outcomes, we've been having a lot of conversations in the VCSE Alliance about how you move away from KPIs and bean counting to the ripple effect, so a decision will have much softer impact on somebody's life than, we use bed days, they don't care about bed days, they want to know when they're going to go home. So how we find a different way of measuring outcomes and how we look for that softer impact. But I think one of the biggest barriers that we're going to be facing is the legislation around procurement and commissioning, and how we procure and how we commission. Because we know that we need to have those regulations in place, we know that we need to have the rigour, but we also know that we need to do something differently, particularly if you're working with community and you're working with VCSE. So how do we influence the legislation and get the legislation changed so that we can work in a much more flexible and dynamic way, but also how do we find a way within the system to move this forward? Because otherwise we've got great ambition here, but the legislation may actually hold us back.
Okay, thanks, Fiona. Gemma, I'm going to pass those to Shane now, because there's just a couple of thoughts. This was always intended to give us that strategic decision about where we head as an integrated care board. The ground has shifted, it's changed, it'll look different in the future. So I guess it's a question for Shane rather than for you about, so what does the future look like with 2040? How does it link into Gloucestershire? Have they got a similar approach? And where does all the stuff Fiona's just talked about sit in the system? Because strategic commissioning might be what we enable, but there'll be other partners around the table who are delivering that. And how do we make sure it doesn't become fractionalised, so we actually do what Joe said, which is actually deliver against some really hard work that you've done. So Shane, I don't know whether you can sort of mop that one up, and then we'll 75 years the NHS.
Yeah, no, well, the reason why we kicked off, one of the reasons we kicked off 2040 was to help us understand how to commission. And that was part of the reason why we did this. Could we understand a population cohort and change the way we commission services to meet the outcome needs, okay? And that's where we are now. We're at a point where we've done one massive learning cycle for a particular cohort. So it is perfect timing now, Jeff, because what we are going to be challenged with is designing a strategic commissioning organisation. And therefore what we've done in Healthy Together 2040 places us in a brilliant position to start to challenge what will our organisation do. So if you take the principles and the intentions, we can turn that into a commissioning framework. How do we commission for those intentions? And therefore, when everyone else, and everyone will be, running around over the next 6 to 9 to 10 to 12 months trying to work out what is strategic commissioning, we actually have the evidence of what strategic commissioning could be. Now, that is not going to be easy in any way, but I could imagine taking the learnings for this particular cohort, creating a overarching commissioning intention to improve the outcomes of that population, and going to our partners and saying, right guys, this is now what we want for our population, collectively come together as partners. That could be under an IHO, so an integrated healthcare organisation contract, might not be, but it's going to partners and saying, right, what is it you can offer us to deliver this vision? And we're not going to measure you on inputs, how many of X did you do, how many of Y you do. We as the ICB will be comfortable to understand the outcome measures and see when the world is changing, and if it is not changing, we're also then comfortable to go back in again and say, right guys, you've not delivered what you were meant to do. So for me, this gives us the building block for strategic commissioning, which is a gift. Okay? Now, I couldn't tomorrow go and commission against it, because that's just not where we are. But it gives us the building block, and I really wanted to start discussing with our local authorities, discussing what's the role of health and wellbeing boards in this kind of piece of work, discussing with our major providers, how do we bring this whole thing together. But we have something that others don't have, which is the building blocks of strategic commissioning, which isn't the case everywhere else. And I am meeting with some senior NHS officials tomorrow to talk about how this connects to the IHO contract, to help them understand this is what we need to do before we suddenly say, oh, and we'll just give providers an IHO contract. That's just not going to work. So if we hadn't done this, we'd have been sitting blindly going, what the heck is strategic commissioning? We've done this. And the other thing, just to stress, we've done this for one cohort. The learning is not just applicable to that one cohort. The learning is very applicable to many cohorts. So take the hexagon diagram and the neighbourhood team. I know it was built up from that cohort. That's equally applicable to other age-based parts of our population. So it's really exciting, but also scary, because we've still got a big journey to do.
Shane, I think that's really helpful, because the way we head as strategic commissioners has to be evidence-based, and this provides a big chunk of that evidence base, because we know if the alternative is there, people will just pluck evidence out of the sky, which is what the man and woman tells them in the pub. And that might be very valid, but this, you know, the effort you've put into this, Gemma, is considerable. You cannot lose that going forward. So my final question then was,
Can
I just ask up this one point, Debs, and the engagement with Gloucestershire, of course Sarah's there as the chief exec now. Are they in a similar position? Have they done the same sort of legwork? Are they receptive to the conversation about 2040? Okay, lots of nods. That's what I need to know.
They're receptive, but they haven't been pointing in the same direction. They've been doing other things, which could also be really helpful to learn and bring into our strategy.
And they have got a different population.
Yeah.
So, okay. Sorry, Debs.
So one of the things that I do think is important is when this was started, the NHS plan wasn't there. But there isn't one thing that we haven't highlighted through this that doesn't appear in some way, shape or form in the 10-year plan. What we've done, as Shane said, is we've got further forward, not just in terms of our thinking, but in terms of the commitment of people who are working in the VCSE, working in the local authority teams, working as our carers and the people that we serve. So we've got that bit of connecting with our community and our frontline staff to have got here, and I think that's the other really solid foundation. We cannot underestimate the value of that.
Yeah, thanks, Debs. Gemma, have you got what you needed? I mean, we've got 3 recommendations. One is around approving the strategic intentions. The second is around endorsing the progression to design delivery plan phase, and then noting the approach to set out to inform strategic commission, which Jane has just covered. Is there anything else you wanted from us today? And then suddenly to board members, is there anything we feel we haven't covered? Because we've had a pretty good airing, but you've done this in lots of places, I know.
Well, today's the first time we've shared these strategic conceptions. You are first. We'll be trading with regards to September, October, different places. But I think it's the points that some of you raised about there's going to be some big decisions around this, what we do and what we don't do, that holding this vision in mind. So the question of, we'll use the risk register approach we have to keep those live, but it might be how we keep this at the forefront of any strategic-based decision making. This isn't just a project coming into those and then the essence of how we operate going forward. So it's how we continue to do that forward will be valuable.
And I think that'll be good for both boards and also for the Strategic Commissioning about how we make sure that we are clear on what evidence we are using, and this will be a really important part of it because it's been really well considered. So thank you, Gemma, thank you, Simon, thank you, Daisy, thank you for all of your efforts on it. Anything before I move us on from this item, and just checking, are we happy to recommend those 3 recommendations? Okay, brilliant, thank you very much. Thank you, everybody. I'll move us on to winter plan then, if I can. Dave.
Thank you, Chair, and I hope this next item brings as much joy to Jay.
The judge of that.
Can I introduce Keith Robertson, who works in the urgent care team at the ICB and has done an enormous amount of legwork in working with system partners and putting this plan together. Just in terms of what we are seeking today, this is, I think I'll probably say, a point-in-time presentation. And although the header on the paper might say seeking board approval today, I'm really here to seek the board's support for the approach that is being taken and seeking feedback, because clearly there is further work to do over the next few weeks in advance of the board assurance statement being submitted. But this was the last formal board before that board assurance needs submitting. So we'll come to that where we go next in a moment. So you'll see from what's been submitted that significant work has already taken place across the system and with stakeholders in developing our winter plan, and it has already been the plan's already been tested significantly a range of forums in the system, including Outcomes Quality and Performance Committee in July. However, there are still further steps that need to take place to enable that full assurance, including individual provider board assurance and also further regional testing later in the month. So, as I said, we're seeking support for the approach today, and I'll come to the next steps in a moment. But there is an awful amount of information we've shared. We've shared a summary deck of information, and we've also shared copious amounts of the backing information. However, this is around context and support for the approach. So I'm just going to draw out half a dozen slides on the screen, just so the board is clear on the approach and the steps that are being taken. So we go to the next slide. So the approach that we've taken this year is very much based on the urgent emergency care plan preparing for winter that was published back in June and was part of Shane's chief executive briefing in that month. And we were guided to provide a response against each of those 5 core areas on the screen, and as you can see from the plan, that's exactly what we've now done. So what I thought I would just do is just summarise some of the key items within each of those areas of assurance. So next slide, please. So I'm struggling with my reading glasses between the main screen and the little screen here. But if I'll just go to the main screen. So in terms of system preparedness, drawing out some of the key points, there is a broad lessons learned event, which I think Keith, you probably facilitated, which really drew on some of the key challenges and lessons learned from last year. That's embedded within the papers, but has enabled us to think differently about our response this year. The System Coordination Centre, although initially when NHS England transition changes were announced earlier in the year, leadership of that was not clear for this year. It is now clear that the ICB will be leading the SCC through to next March, and we have embedded our processes and staffing to enable that through to the end of March. The system risk approach, we continue to develop and embed this year with a dynamic risk approach, which is going to be tested through HCPE next week. And we are still leading and working with further national teams to further enhance our plans, notably the Getting It Right First Time team at MBT, and across the system working with Empower, focusing on our intermediate care plans. So that's the kind of key points in terms of focus area 1. Focus area 2, next slide please, reducing demand and improving access. We noted, I think we brought the vaccination programme success of last year through OQPM, but again we've learnt from that programme this year to making sure that we are absolutely targeting on hard to reach communities and populations. That is having a renewed vigour and has already started this year. We are proactively investing this year rather than waiting for gold calls and Opal 4 status to look about how we invest in additionality in Home First capacity, and we are working that through with local authority and Serona colleagues. I'm not talking to all of them, just drawing some of the key points. Focus area 3, please, next slide. A key area in terms of improving flow directly through hospitals, both in terms of front door and in reducing hospital delays and hospital discharge. At the front end, the timely handover process with SWAST has been implemented on 3 acute sites. And in my performance report, I'll note later the initial early success in that. Key to our success this winter is our discharge improvement programme and our further efforts in reducing no criteria to reside. That is absolutely critical in the delivery of this winter plan. Next slide, please. And just to reiterate that, what we have done very carefully with our trusts, with the providers this year, is to align provider bed capacity and bed modelling with our system trajectory for improving flow, and that has enabled a level of confidence around the bed modelling such that if we meet our trajectories for no criteria to reside, there is a balanced bed position going into this winter. That is where we are at this point in time, but as I've said, that is going to be further tested through these NHS England events over the coming couple of weeks. Next slide, please. Focus area 4 is a focus on mental health crisis response, and here there have been some new escalation standard operating procedures developed by AWP, focus on high intensity users and developing plans around crisis assessment centres. That's still in development. And the final area of focus, next slide please, is around digital transformation. We heard earlier around our potential use of the Federated Data Platform in developing our live system data tools, which we'll be working through this year. We have invested in technology-enabled care to make sure those tools can continue to be utilised through this winter. So those are the core kind of focus areas. I wanted the board to be clear on the approach that we're taking in responding to those focus areas. As I said earlier, we are implementing and developing a dynamic risk assessment approach this winter. And that approach is going to be reviewed through HCPE and SQG, apologies I can't remember the acronym for SQG, System Quality Group, later in the month. Thank you, next slide. So just to summarise, all of this has been worked up and developed through individual conversations with partners, but also the range of system groups that you can see on the board was tested at Acute Health and Care Improvement Group last week. Performance executive meeting last Friday, and I'll be bringing the plan through the System Executive Group later in this month, and the Community Health and Care Improvement Group this month. So good system-wide engagement in that plan. So what I'm seeking today is support for that approach, take any further feedback in particular areas for people might identify for further work over the next few weeks. And as I say, the board assurance statement is in the pack. What I'd seek today is delegation for approval of that board assurance statement to to a discussion at the System Executive Group, which is already planned for the 30th of September, and also a further check and challenge session with Ellen and Alison as Chair of OQPM towards the end of the month, to make sure that we've captured all of the key questions and discussion from OQPM. So delegation to SEG and Ellen and Alison's OQPM test.
Okay, thanks, Dave. I mean, really comprehensive. There's a lot in there, isn't there? And there's a lot of engagement across the system in what's been drawn up there. You've read through the 2 recommendations, which is any feedback that we've got, but also that delegated responsibility to the exec group. Any comments, observations for people on it? So, Ellen.
Yeah, can I just sort of add something as Chair of Outcomes, Quality and Performance? Part of this is my update anyway. We did have an earlier update at the committee, so we had the opportunity, even though plans hadn't been fully formed, to provide quite a bit of challenge to Dave, because committee members had been there for the last probably 2 winters and seen some successes and some challenges. For us, some of the feedback we gave back is that no criteria to reside is absolutely key. We've been talking about it for quite some time. We haven't shifted the dial sufficiently, particularly on stroke. As we are today, we've not made necessarily the progress we would like. So what's important, and I've sort of discussed this with Dave, in order for board to take assurance of this, I think it's really key that Alison and I do have that session with Dave, that we prod and poke. Dave's very happy with that anyway, and test some of the detail. So just to give you some examples of areas that we probably wanted to test, the integrated care at home, which is really important. It's not been procured yet. Is it going to be procured on time? They'll be the questions we'll be asking. The new area performance meeting, there's a rotating chair. You know, does that person therefore have enough accountability? So we'll be just questioning areas like that, Jeff. So just want to sort of suggest to the board that that's an extra level of assurance for them, that Alison and I meet and ask those probing questions.
Thanks, Ellen. That seems really positive. Shane, just thinking on what we're going through now. Obviously, if this function passes to NHSE as a region, particularly our performance assessment, have we thought about how we're going to capture the experience and the learning to pass that into the region?
I think there's a huge amount of conversation ongoing about what the future of performance management will look like, and I don't think it's that binary, Jeff, if I'm being perfectly honest.
No, it's not that binary.
You know, I don't think they'll simply be handed across the fence and then HSE will run with it.
But, so they will have the responsibility performance, not ICBs.
Absolutely. Therefore, that's one of the pieces of work that's being done on a national and a regional level. So, because it will not simply be handed across.
So Richard and I just had a brief conversation over lunch, actually, because there's going to be an overlap between performance and contract management, and, you know, so the area in between is going to be sort of, you know, there's going to be quite a big overlap, and one of the sort of areas of probably frustration for the likes of Maria has been, you know, too many people asking too many questions. So I think Richard suggested that we have some shared learning, so that, you know, he can understand what we've been through and the journey that we've been through, and also perhaps sort of learn some lessons. So I thought that was a good idea.
I mean, that's bringing in now, Richard. The duplication of effort is always enormous, isn't it? If the conversations are taking place everywhere in the system. Dave, what you presented there is a really good join-up of what's being done, but we don't want to lose that, do we? So, Richard?
Yeah, just to say it's been frustrating the last few months because we haven't had the model region publicly announced to sit alongside and have the conversation. We've now got that approved through the NHS board, so we can start having that conversation with you. And I think, as Shane said, this is not us taking something from you, it's how do we do it together, partnership model that we've got to work through. So keen to work with you on that.
Okay. Alison?
Just, I mean, there's such a lot of work in this, isn't there? And Keith, there's such a lot of work in this that you've done, and there is a good battle rhythm over the last few years. I've had confidence in the leadership in trying to address this across the system, and so I think that's really good. I guess the nuances for this winter is how fatigued is everybody around the system about getting towards another winter, because we're asking people who are working incredibly hard to do more, and maybe not to answer now, but in terms of the prodding, but also in the sense of, with all of these things to do, it means that partners need to agree there is still room for improvement in their part of the system. So I guess there's just that, it's the nuanced bit about the human side of it. How much further can people think they can go, and is there general buy-in for that? And also, how do you get people who remember last winter and they remember the winter before and they remember the winter before? How do we get them energised with this type of plan for this winter? So you may want to think about it now, but you might.
Let's start with a stab at that. So I think there's a bit of excitement for this year is the first time we're doing proactive investment in some of our reablement and the home care services. So there is a bit of enthusiasm to think actually this is a different change from last year.
Right.
I think the other bits we need to probably consider is we've put a governance structure in place, but some of the pressures that do appear emerge, and perhaps we haven't got a governance structure in place to deal with that emerging pressure. So I think our agility and ability to respond quick enough as a system and respond to that is going to be helpful. I think people in the economy can recognise that. I can't speak to people's enthusiasm, but so far they're enthusiastic, but we'll see how we go through.
I'm going to go and then segue over to Maria in terms of how staff are feeling. What I was going to offer is the key element is clearly our continued effort in terms of no criteria to reside reduction and what we called our community discharge programme. And what is positive this year and signals a shift in approach is providers and individuals providers are stepping up to lead those programmes as opposed to us actually leading individual programmes. So that there is genuine buy-in from local authorities, community providers and acute providers leading those work streams and then delivering against those work streams. So that's been really positive. And then my other final point on that, the other nuance to approach this year is our governance around that community discharge programme. We have a trajectory, we have length of stay targets, month by month through the winter. And the moment we start seeing deviation from those, which have been reported through System Executive Performance and Recovery Board, will be mitigating and taking action against those. So just a further level of assurance this year.
I mean, it appears from chairing the board that we've made significant grounds in the way we coordinate effort and that we work collaboratively across the system. And I suppose going forward, if that isn't there in that present, what does it look like and what adds value? So Maria, you're probably best placed to answer that really, because at every board meeting you'll have your winter plan will be on the agenda, pretty much. So as we go forward as a strategic commissioner, where does that add value, and where is NHSE going to be a bit more remote than perhaps we are within the system? So I don't know what you think.
Well, a couple of things. First of all, about where staff are at the moment, which I think when the sun's in the sky, everyone's away on holiday, and you're talking theory. It's lovely to get engaged in these processes, and it will be in the test as we move into it, and weather changes, etc. So energy good at the moment, but there's always stuff, and we'll have vaccination programs to carry out and all sorts of other things too. I think the most helpful thing is back to the convening role, actually getting people round, stress testing. So I just wanted to, I suppose, for us to be very, very clear about the role of local authorities in this, what can open up and flex very, very quickly if there are surges, and the role of the ambulance service. Because actually if you're having 20 ambulances turn up in 2 hours somewhere, you are in a very, very different state. And winter, how people tend to think of whether winter has gone well or not is how many ambulances you're seeing queuing around the block on television. And that is what people end up thinking has been a good or bad winter, and all bets can be off in terms of public confidence, etc. So I think some of the ambulance discussions as well would be really helpful to convene. How do we know that there will be better alternatives than just piling loads of people up outside an ED which is already full?
Okay, thanks.
Oh, sorry, one last thing. The test about absolutely brilliant that we will be commissioning alternatives to ED attendance, but that is a human behaviour thing as well. So just having them there when people have been used to going on a certain path, we need to start that education now. If we're only commissioning them later, we haven't
helped people think differently, they won't use them properly.
So I've got Dominic and Jaya.
So my comment is slightly tangential and might feel slightly wrong, but I just feel moved to say it. And I've been in the NHS, I think, 16 years now. 16 hours of these grants, 12 in mental health. But in mental health, there are 30% more admissions in June and July than there are in December and January. We never talk about that. So maybe we should be thinking about some rates coming. And if I look at just some bald statistics, so we have 200 beds for adult acute mental health patients. You might think that's a lot, you might think it's a small number. Firstly, that's 70 beds less than benchmark would suggest that we should have. Right? We also average unfunded 24 out of trust placements over the last 12 months. That's against 63 patients who are clinically ready for discharge and waiting for social care or housing. When are we going to talk about those things?
So Dominic, I think those are points really well made. And when we had the conversation this week with Jim Mackey, there was two things he laboured. The one was mental health, and the other was maternity. Both of which we one we're discussing here, the other we got on the agenda for today, because they've been hidden crises, and actually what you described, I bet most people would be completely unaware of that, wouldn't they? About the things you've just quoted, and because it's hidden until you have an experience in your family. But I mean, they're good points. They're good points. I suspect that transitioning period will be making sure that we are keeping a hold and a grip. Hold's not the right word, but we are keeping a grip on the way we're all doing things. Is going to be really valuable, and also how we're not losing everybody's voice in that conversation. I think will be really important, because we could get very tunnel visioned in the way we look at winter planning. Dave, that was a really good presentation. Is there anything else anybody wants to cover on it for now? I think I'm hearing support for what you presented, and then delegation to the exec group. Unless anybody's got any views to the contrary on that? No? Okay, brilliant. Thank you, and thank you, Keith. Thanks for the input. Transition Committee terms of reference. Shane, you start us off, and then over to Rob, or
I just people will know from keeping an update that an important part of our governance journey is to create governance of the new cluster, is to create a transition committee which will enable us as a committee of our board and a committee of Gloucestershire board to start to move towards delivering a new clustered ICB. So Rob has been working very closely with Tracy, his equivalent in Gloucestershire, to begin to develop a terms of reference. And Rob, you want to just explain a little bit what's in the terms of reference and what we're asking the board for today?
Thank you very much. So it's clear in the model ICB blueprint that a transition committee made up of executives and non-executives is a requirement, hence the request today to this board to establish what we have decided would be a joint transition committee across our cluster with Gloucestershire. So in line with our scheme of reservation and delegation, to establish a formal committee, the board has to agree that, and it has to have terms of reference. So those terms of reference, as Shane has said, have been jointly developed with Gloucestershire. From the BNSSG board today, I would like approval, please, for the terms of reference, which I will go into briefly in terms of membership, etc. But with the intention that the committee is authorised to make decisions on the planning and delivery of the reorganisation of the clustering ICBs, including the design and the structure of the organisation, its workforce, obviously triggering any necessary consultations, making sure that there is the necessary costs available in order to do that. There will need to be close working if we're talking about organisational changes with REMCOMs, because NHS England require business cases to go through REMCOMs, and we will come to joint arrangements or in-common arrangements separately for those when the time arises. Equally, with audit and risk committees, and as we've already touched on, firstly this morning, and then secondly when we were talking about the outstanding actions from the last board, there will be risk registers for the joint transition committee, which will be shared with the audit and risk committees. The intention is that there is a joint transition committee. Jeff, I know that you have been in conversation with Gloucestershire colleagues as well in establishing what that membership might look like. The membership is in the terms of reference from a BNSSG perspective, 2 non-executive directors, a partner non-executive director or executive director and chief people officer, and respectively same individuals, same posts in Gloucestershire. A chief finance officer from one of the organisations, obviously to bring the resource side of things to the conversation, and also the chair of the BNSSG Independent Advisory Group on race equity will be invited. And the intention was originally that the Gloucestershire equivalent would also be part, but Gloucestershire were happy with Tracy Jolliffe fulfilling that role. So within the cover sheet, it then tells you what I'm asking from this board, and it is to agree the terms of reference, noting that Gloucestershire are having to go through their agreement process with their own board as well, and therefore I'm asking that Jeff as chair is able to also agree any amendments which might result from Gloucestershire's board, Jeff's board, any tweaks that might need to be made, that our BNSSG scheme of reservation and delegation is updated, and in the paper I've told you what I was proposing to put in there without having to show you the whole scheme of reservation and delegation, and we're following a similar pattern there to what we did when we accepted delegated commissioning and we took on the South West specialised commissioning arrangements with the Somerset ICB leading on those governance arrangements. And then just to note that the terms of reference and the updated scheme of reservation and delegation, if you agree it, will be published on the ICB website as part of the governance handbook.
Okay, thanks, Rob. It's not mentioned in the membership. I have asked that local authority chief exec is part of that transition committee. And I think Jo Walker's happy to do that because she obviously was chief exec in North Somerset and now has gone to Gloucestershire. And I also sent a message about us here with engagement with local government. The other one I'd asked was we have a non-exec director from SWAST on the transition committee because they look over all of us and they probably haven't got a vested interest in what the new structure looks like other than it works. Originally my intention was one non-exec director from each of the ICBs. Gloucestershire pushed back a bit about that. They want their deputy chair on there and one other. Well, if that's the case, then then BNSSG needs to have an equivalent on there. So my feeling is, and it's not in the paper, but my feeling is that obviously Alison as the deputy chief exec should be there, but that John should be there because they're linked to audit. And actually the auditors are going to play a big part in the way we transition from our existing ICBs into what the new organisation looks like. So I'd be really keen to keep that link in the conversation there. So I think probably John is the best person to sit there. But this isn't cast in stone around membership, so I'd like to get some feedback around it. The other thing was we could have made this a lot bigger, but it has to be a committee that makes decisions and moves on and gets things going. And you are going to have the chair and the chief exec from the cluster and obviously from here set on that committee and driving the committee forward. So, Shane, anything else you'd want to add about it that's not in the...
Nothing to add apart from it's just so important we get cracking with it?
Yeah, absolutely. Absolutely. And I've had a little bit of to-ing and fro-ing with it, part of which is because the appointment of the chair wasn't made until Monday, you couldn't really make any decisions around it. But I think we can move a bit more swiftly now. So hopefully you had a chance to read the paper, so I'll open up to questions. So I've got Jo and then Dominic.
Yeah, I know there isn't any clinical leadership or any reference to clinical governance, there's governance. Is that purposeful and is it required within this transition committee? And if it was, what should that look like?
Good question. I mean, who's best placed to answer that? I mean, I'll have a stab at it. Actually, when we're commissioning going ahead in the future, how can we do that without clinical engagement, oversight, observation? What that looks like in the structure, I think, will be open to discussion. Whether we need it in transitioning committee, I don't know. Shane, have you got a view?
It's more about sort of close understanding the statutory responsibilities, that broader remit. it was just, and it may be required. It is a genuine question, but I was just, as I was looking, I thought, oh, hang on, is there a gap?
Yeah, I suppose I would envisage that depending on the decisions that have to be made, we need to bring experts into the room. And so this committee will simply be the standing committee. When we're starting to talk about stuff about technology, we bring the expert into the room. So I actually think I would envisage that although the committee members are here, I think there'll be a lot more people at the committee as experts in the room. Whether they're on the committee, I don't know, Jeff, that hasn't really been discussed.
I think it's a fair challenge because what's in the conversation, I think you're probably right, Shane, because there's so many aspects of clinical provision, and do you invite someone from the acutes or someone from the existing ICBs, or do you invite someone from primary care in? So I think it might be dependent on what the conversation is. But Joe, I think it's important that we're getting feedback here that if we are not capturing what needs to be in there, that's fed back in, and we need to be responsive to that pretty quickly. But I guess this was a first stab, and I think we need to establish that committee. And if it's working, great. But you'll be the judge of that when it comes back into the board. If it's not working, then we need to know quite quickly. Any other comments, Dominic? Sorry.
So mine is analogous, actually. I understand that providers will not be on the new ICB boards. That's above our pay grade. It's been for better or worse. But that just makes me wonder, and it's probably slightly outside of this group, but should we form some kind of provider reference group across the two, so Kevin and Douglas in Gloucestershire, so we can effectively give you a reference group that you can then use to sense check?
Yeah. For me, Dominic, SEG, and I'm going to call it the mega SEG, which is bringing SEG in from Gloucestershire as well, is exactly that. Because you're dead right, I don't think I'll be allowed to put providers on the board, but I'm going to push back on that. But we have system exec group, and therefore for me, SEG have a huge role to play in this.
Well, what if we don't want you in the room?
Well, we're going in the room, well then, go.
You don't get any money.
Yeah. So for me, SEG is the place where we'll do that, Dominic. But I think on record it would be great. I want to create a board that is inclusive, and although the 10-year plan says providers won't be on boards, I think we need to explore what that means, because you might not be on a board, but you could be in the room, and I just think it's really important to think that way.
But again, a good challenge, Dominic, because how we make decisions going forward has to be collective, not, you suddenly get a decision that comes out to you where you say, well, I haven't had a chance to discuss this. So, yeah, good point.
Well, if I may, point 9.1 in the terms of reference does allow for, due to the focus of the committee's work and the nature of emerging guidance, these terms of reference were kept under review on an ongoing basis to ensure the continued fitness for purpose, which I think is kind of like reflective of where I think we are now. But I guess, Jeff, for the joint transition committee to work and to get on with it, there needs to be some level of authorisation from this board today.
Yeah. So Ellen.
Yeah, can I just add one other thing? I think on the back of Dominic's, actually, I think you make a really good point. And I think also just making sure that the board, up until sort of next March or April, or however long, the representation of partners is really, really important. I mean, winter is, it's based on, Maria mentioned it, sort of local authorities being in the room. We've got a position today where, great to meet you, Mandy, but we've got two local authorities that are not here.
I think it clashed with the meeting.
Oh, okay. I think it's just really important that we emphasise the priority of these board meetings, still really important, keeping sort of partners in the room, because there's important work to do. This will then take us on to the next phase.
Absolutely right, right at the start of this morning about this is the work of the board, of what we do.
Yeah.
The transition committee is about creating a future, but it doesn't do the work of an ICB, not yet.
Yeah.
Okay. Richard.
Just share a couple of reflections from the extraordinary Gloucester board where they talked about this, many of the same topics there. Really emphasised the transition committee, the relationship with this board and with the Gloucestershire ICB board is really critical. And effectively, this board is still the fundamental point, but the transition board works in service of and works with as well. The other thing that got explored was or we could have these people and we could have these people, and suddenly it started growing, and the decision was very clearly made, let's try and keep it tight, but have the relationships, have the links in and out, and see it in that way. And that was kind of the same conversation that played out there.
Yeah, I mean, my thinking on that was, because I had the conversation around the Gloucestershire meet, it's about keeping it the right size, but also, yeah, I suppose we've got to be a bit careful about the representation on the strategic committee not being people who are conflicted, because their role may go, and that's definitely the case for non-exec directors. So I started with it today. We've got 10 non-exec directors. We're not likely to have that in the new structure. What I don't want to happen is to make sure that those non-exec directors who appear on the strategic committee are the ones who are selected to be on the new organisation. You know, that's not the way that works. But I think we come to a sensible solution on the numbers that'll sit there. And I think it might be a bit of a movable feast. Any other comments or questions? So we've been asked to do 3 things. 1 is agree the terms of reference for the committee. 2, agree the ICB scheme of delegation to affect the role of the committee, set out in Annex 3. And the 3rd one is noting that the terms of reference and revised scheme of reservation delegation have been published on the ICB website as part of the governance handbook. And we'll replicate this with Gloucestershire as well, going through their board. Any adverse comments to that? No? Okay, thank you very much. I think it's agreed. Response to National Maternity Review. Layla, where's Layla? There we are. Hi Layla, nice to see you again. I think you're going to set us off on this because Rosie's not with us.
Good afternoon, everyone. I think most of you know me. I'm Layla. I'm Deputy Director for Quality and Safety for Maternity and Neonatology within the ICB, and I'm the clinical lead for the local maternity and neonatal system. And I'm here today to provide an update and assurance to the ICB board regarding the system-wide response to the rapid independent investigation into maternity and neonatal services, which was announced by the Secretary of State for Health and Social Care on the 23rd of June this year. What we do know so far about the investigation is that it's going to be a Darzi-style rapid review, focusing on 10 trusts where specific issues have been identified, and is currently due to be completed in December. As it currently stands, the chair has been announced as Baroness Amos, with the terms of reference currently being developed, and the 10 trusts also haven't been finalised as yet. Whilst this review is ongoing, all local NHS boards with responsibilities relating to maternity and neonatology have been asked to address 5 key areas. So what I'd like to do today is just draw your attention to what those 5 areas are, and then to provide the system-wide response from BNSSG. So the 5 areas I'm also hoping aren't going to come as a major shock to you, and are things that hopefully you'll recognise that we have been discussing during board meetings ongoing. So number 1 is be rigorous in tackling poor behaviour where it exists, and where there are examples of poor team cultures and behaviours, they need to be addressed immediately. And number 2 is listening directly to families that have experienced harm at the point where concerns are raised or identified, that they're listened to at that point. It's also important that we create the conditions for staff to speak up, learn from mistakes, and at the same time staff who repeatedly demonstrate a lack of compassion or openness when things go wrong get robustly managed. Number 3 is all around the maternity and neonatal voice partnership, which we've discussed at length within BNSSG. And this is all around, again, ensuring that the right culture is set, supporting, listening and working through co-production with our maternity and neonatal voice partnership, local women and families. The 4th point is around data, so it was quite interesting, the conversation earlier. So review your approach to reviewing data on the quality of your maternity and neonatal services, closely monitoring outcomes and experience, and delivering improvements to both. And lastly, retaining a laser focus on tackling inequalities, discrimination and racism within our services, including tracking and addressing variation and putting in key interventions. So, as I say, the report that you have in front of you is quite lengthy, but I'm just going to pick out some key areas of where we feel that as BNSSG we are working well, and also where we need to continue to develop. The report that you have in front of you has been developed by Sarah Winfeld, who's the Director of Midwifery at UHBW, Julie Northrop, the Director of Midwifery at North Bristol Trust, and myself as the LMS lead. And it has already been presented to the Bristol Hospital Group Board by Chief Nursing Officer Steve Hams, so it's just really important that it's recognised that this has been a really collaborative approach. Excuse me, as many of you know, North Bristol Trust and University Hospital Bristol and Western have come together to form the Bristol NHS Group. So we are now one of the largest providers of maternity and neonatal services within the country, and deliver over 10,000 babies annually. Both MBT and UHBW were rated good in the last CQC investigations in 2023, with the MBT improving its safety rating. And it's also important to note that both trusts participate in national safety and quality improvement programmes, including the Maternity Incentive Scheme and Embrace UK. And we've brought both of those things to the board previously. And as you will know, the Maternity and Neonatal Voice Partnership has become really embedded within BNSSG to ensure that the voices of women and families shape our services. So what I'd like to draw your attention to is areas within each of the 5 points. So within tackling poor behaviour and team culture, I think it's really important to recognise that both of our trusts have staff that have participated in culture and leadership programmes, including Civility Saves Lives and the Perinatal Leadership Programme, which concentrates on improving culture at that quad, at that leadership level. From a staffing point of view, staff are regularly surveyed, which it's recognised that that does have its limitations. But action plans targeting staff wellbeing, communication and performance management are integral to everything that is done within maternity. However, we do recognise that we need to continue to focus on these areas, because culture is one of those things that is really difficult to pin down. And it's also been recognised that improving the multi-professional teamwork would be of benefit, especially in our maternity theatres and our neonatal units. Around listening to families who have experienced harm, duty of candour is a standard procedure, and all of our families are regularly involved in debriefs and complaint resolution. We also have specialist teams within our bereavement services and patient experience, which offer support to families, and we have regular listening events for staff to be encouraged to raise any concerns. As I said previously, patient and staff feedback is actively monitored. However, engagement in staff surveys is an area for improvement, because we know we don't hear from everyone. And actually our MMVP are going to be doing some work, targeted work with staff around how psychologically safe they feel to raise concerns at work. Our maternity and neonatal voice partnership are embedded within everything that we do. Our MMVPs are involved in all of our safety, quality and governance meetings and are corporate on all of those. They take part regularly in the safety walkabouts, and they're currently working on some initiatives around improving estates, which will obviously help staff wellbeing and an antenatal education redesign. I think we're particularly proud within BNSSG about the work that we're now doing around community engagement, because I think we recognise that was something that previously we didn't do as well as we could. And we've got a massive focus at the moment on underserved and vulnerable groups, and we regularly work closely with our BCSE organisations. Specifically, Black Mothers Matter, Project Mama and Bristol Women's Group have been really key partners to the work that we've been doing. However, complacency is something that we're always aware of, and we know that there's a lot more work that we need to do around patient information accessibility, around digital engagement and translation services. However, we have recently commissioned the Real Birth Company to improve our antenatal education offering, and they have a digital offering that's available in multiple different languages. So we think that's going to be a great improvement. Around data, I think that this is something that we've discussed so often, and within maternity services we do have a huge amount of data at our fingertips, but it's about how we use it intelligently. And our trusts, although we currently use the perinatal quality surveillance model, we have patient experience groups that ensure ongoing scrutiny and improvement. I think the system-wide dashboard that we're in the process of developing, and that is nearly finished, will give us that intelligent data where we'll be able to look at our outcomes and then actually break it down by multiple demographics, so we'll be able to see where our inequalities lie. And this has been a really important project that is being collaborative between MBT, UHBW and the LMNS. And UHBW is also the pilot site for the new maternity outcome signal system, which you might hear being called MOS. It's one of the initiatives in the 10-year plan. And this assists in identifying potential safety items as they arrive. So that's quite an exciting project to be part of. But we do know that we need to improve our data quality. We don't want dashboard fatigue by there being so many dashboards that we don't know which one to look at. So again, we are very aware of that. And lastly, and most importantly, within the inequalities field, both trusts and leaders in anti-racism training, notably through Black Maternity Matters, as you're all aware of, we have diversity and inclusion midwives, EDI advocates, targeted continuity of carer in our areas that have got the highest deprivation. We've been part of the RHO project. However, again, we do know that we need a future focus on other protected characteristics and to further embed more anti-discrimination training for all staff. I know I'm running out of time, so I hope that this demonstrates that BNSSG has a robust, structured approach to implementing the 5 immediate improvement actions, that we've got a strong focus on safety, learning, culture, co-production with women and tackling inequalities, but we do need to continue this close focus to be able to continue with these good outcomes. We will be meeting as a system at the end of October to track our progress against the areas of development, so I'd be really happy to either come back then or to come back once the learning has come out of the National Paternity Review in December.
Okay, thanks Leila. Really comprehensive as always, really important for us, the board, and really important we're here in this board level as well, so thank you very much. I don't think we're looking for a decision on anything here today, it's for the board to note, but any comments or questions, Joe?
Yeah, it's a great report, Leila, I mean really detailed. The only bit I would add, and you're going to roll your eyes I'm sure, on the things that are to be developed, where you can see what you're doing, you can see where the gaps are, I would like some smart objectives in some of those. So when's it going to be done by? What is the number we're aiming for? And it hasn't got to be in all of them, but I think it would just give some realism and some grit to the report and add power to the report. So again, there's only about 4 or 5 in there to be developed, but I think if you could just flip that in with some smart objectives, it would just improve it a bit.
Yeah, that's a good point, Joe. Thanks. Alison.
I think this is a fantastic baseline, isn't it? And I really like the fact you're saying about not complacency, but for our system to have 2 maternity leaves at very good ICBC is really good in lots of ways. The letter wasn't specific, and I should have asked this at Captain's Court at Frontline, I forgot that. Perinatal mental health services also look on, they aren't in, this is about the acute trust. And neonatology, the definition is 28 days post-birth, so health visitors also. So the letter's quite, I don't know, are we capturing all the services that look after maternity patients and neonates, or is this specifically meant to be a trust piece of work?
So this was something that came up when we took this to our system quality group. So I think initially this was very much acute provider led, so our neonatology colleagues were absolutely involved and our perinatal mental health teams within the trusts. But the challenge that we had at System Quality Group, which I think is really, we really listened to, is that actually AWP weren't part of this initial response. So I think what we will look to do, and it went to System Quality Group a couple of weeks ago, is to bring in our wider system partners, bring in Serena and our health visitors. We work really closely as a system, but they weren't part of this initial response, and I think that's a really good challenge.
Yeah, thank you very much.
Any other comments or questions? Maria?
Thank you very much, Leila. I would like to acknowledge some of the work that's gone on in the Trust, because they were not in this position maybe 4 years ago, as some of the board will recall. So a lot of work has gone on, and in the fortunate position of having good CQC maternity reports, and very few of which actually upgraded. So obviously a good recognition. We're certainly not expecting to be on that top 10 list to be investigated. So this is building on success, but my point was about the absolute necessity of inclusion of perinatal mental health. As we look at this, it's a very, very important part as we look at those first 1,000 days, of course. The differential outcomes are still very stark. Lots of work has gone on, but that is something none of us can sit comfortably with, and huge amounts of work. And we are working with some of the VCS sector in support of understanding some of the culturally appropriate behaviours that perhaps aren't being exhibited in a way that will make people feel comfortable and wanting to come to the services earlier. A last point I must make is services are fantastic. They're sometimes delivered in very poor quality estate, and we have had some safety issues and some risks around our maternity estate. So that also, whilst not necessarily a part of this programme, it is something that does affect the teams on a daily basis. And of course at St Mike's there has been some difficult safety concerns around fire risks as well.
Okay. Maria? Any other questions? Okay, can I suggest we have a 5-minute break, let people stretch their legs, fill their glasses if they need to, and then we'll do the annual accounts and the updates from committees. And I'm looking now, I think we'll probably be finished around about 3:30, I would think. But we shall see.